And our next stop is about antibiotic stewardship. And stewardship means responsibility. Doctors, pharmacists, veterinarians, microbiologists, all making informed choices, guided by diagnostics and data. It's not about saying no antibiotics, but about saying yes to the right antibiotics in the right dose with the right administration mode for the right duration to the right patients. Stewardship programs in hospital improved patients' outcomes. On farms, alternative to antibiotics are transforming veterinary practice. So please welcome Lida, Politi, and the team reporting on antimicrobial stewardship. And please, all the team, when you speak, stay here. Thank you.
Hello, everyone. I am Lida Politi. I'm from the National Public Health Organization in Greece. Antimicrobial stewardship is a central pillar of the EU-JAMRAI 2 project, and it is a key priority for member states in addressing antimicrobial resistance through a One Health approach. Within this project, we aim to strengthen antimicrobial stewardship capacities across human, animal, and environmental sectors, while directly supporting countries in the development and updating of their national action plans on AMR. Our work is structured around a very clear logic. First, building a strong evidence base. Second, translating this evidence into shared frameworks and tools. And third, supporting implementation in real-world settings. This session is structured and organized to reflect that logic and to present how the different tasks contribute to a coherent One Health AMS approach. Before moving into the individual presentations, however, it is very important to briefly highlight what has already been delivered. Over the first phase of the project, we focused on building solid foundations for antimicrobial stewardship across sectors. This started with extensive evidence gathering through surveys and literature reviews covering AMS in human health, in animal health and the environment, as well as behavior change. This work has allowed us to identify key barriers and drivers for antimicrobial stewardship implementation and better understand where countries share common challenges, face common challenges, and where solutions can be shared. In parallel, we invested strongly in connecting countries and professionals through workshops and exchanges, creating the basis for collaboration and mutual learning. These foundations are now being translated into common frameworks, guidance, and practical tools, and these you will all find and hear in the presentations that follow. I would like, at this point, for our colleagues in 6.4, the behavioral change, to join us. Thank you.
Can I have the first slide, please? Hello from me. My name is Katerina Iliopoulou. I am from the National Public Health Organization in Athens, Greece, and today, along with my partner, Josera, we are going to present the progress of 6.4 working package, which is about antimicrobial stewardship, which is about behavioral change strategies in antimicrobial stewardship. Can I have the first slide, please? So the aim of 6.4 is to enable healthcare professionals to design and implement behavioral science-informed interventions, which means to make behavioral science accessible to AMS teams. Antibiotic prescribing is a behavior, and in order to improve prescribing, we need to change behaviors that leads to overuse or misuse of antibiotics. It was heard before that we have education, we have guidelines in AMS, we know that they both work, however, they are not simply enough, because prescribing problem is not a knowledge problem, it's a behavioral problem. We also know that there is a lot of variability in prescribing practices amongst clinicians, across departments and across hospitals. However, we have these behavioral determinants or factors can explain this variability in practice. And what it makes more complex in prescribing behavior is that it's influenced by context, because context matters. What it works in one, for example, primary care in Germany may not work in another setting in Spain. So the approach, one size fits all, fails because we know that healthcare professionals and healthcare systems are fundamentally different. But we have good news. We have behavioral change frameworks, theories, and models in our hands, which allow us to diagnose why professionals prescribe as they do, and to design targeted interventions that, that stick in practice. But the paradox is that although we have this knowledge in our hands, behavioral science is largely underused in AEMS interventions. 6.4, briefly I'm going to tell you, has 4 subtasks. 6.41 is about selecting the best fit behavioral change model in AEMS. Subtask 6.42, it's about developing an AI-assisted intervention design platform. 6.43 is about developing and piloting, testing an online scalable training program for AMS interventions. And 6.44 is about designing interventions for behavioral, for prioritized AMS behaviors. The first subtask, 6.41, we selected the COMBI model, which was very well described from the partners of 7.4. We developed a report which completed in December 2025. Why we selected COMBI? First of all, there is a substantial empirical support. COMBI 2 is about to be published soon. COMBI is a comprehensive diagnostic hub which allows to identify context-informed prescribing behavioral determinants. It's broad and flexible, which means that it can be used with other more detailed frameworks like the theoretical domains framework, and this adds granularity for intervention design and evaluation. It's adaptable across complex levels and audiences. It has global endorsement. It has been used by World Health Organization in the TAB program. And finally, it is aligned with 7.4 activities, and this enhances JAMRAI's impact in adopting behavioral science in AMS. José, the floor is yours.
Thank you, Katerina. I'm José Ramón Paño. I'm infectious disease physician at Aragon Healthcare Service. Aragon is a region in Spain. And as Katerina said, context matter a lot in AMS and in behavior change. So before diving deep into the next subtask, we wanted to better understand the context of AMS in human health in the EU. So jointly with task 6.1, we developed a questionnaire to try to explore 2 aspects. One is how is AMS organized across countries and in different healthcare settings, and in the second is what is the actual knowledge and expertise on behavior change through among AMS experts. So we developed this. We just performed this survey, and we found a couple interesting things, which, by the way, were expected, but it's important to see them in written. Is that the level there were differences across countries, significant difference, organizational difference across countries, and regarding the resources, and also and also regarding the settings. So how they self-consider every country prepared for AMS in the different settings. The hospital was the best prepared, followed by primary care and long-term care facilities. I mean, AMS is quite less developed. And regarding the behavior change, there was a universal need and ask for more education and support. And I mean, this was universal. So this fully justifies the next steps of our substacks. One is to provide a comprehensive training program that is broadly accessible for AMS. And second, we need to make behavior change easy to AMS stewards. So they need tools. And Katerina, please.
The next slide. I don't have much to share with you about 6.43 because we've just started. Our first meeting was held last Monday. We have in our group 18 participants from 8 countries. The experts have moderate to extensive experience in AMS, development and evaluation of training programs, behavioral science, and the co-design approach. We agreed that we have to utilize a co-design approach throughout the development of the content of the program. We consider that we may need to target all participants in hospitals, primary care, and long-term care facilities. And something that is missing from this slide, that we aim to utilize the digital training resources which have been posted in JAMRAI's website. Next steps is to identify our potential users, the content, how to evaluate its impact, and the level of content's depth. We aim to develop the first demo by January 2027.
And then the tools, because how can we help AMS antimicrobial stewards to adopt behavior change for intervention, design, and implementation? And you know, the AI boom just started in November 2022, and it became clear to us that AI could be a tool that could boost all our activities. So what we decided in this task is that the tools to provide to AMS stewards should be AI-based, and we wanted to provide tools that guide AMS stewards into this process, the COMBI process adapted to AMS. So finally, working with engineers in our group, we decided, I mean, we've been discussing on the architecture of this AI-based tool. And we decided that the best way to go is through a multi-agent system that guides AMS stewards, which are not experts in behavior change, in this process, the COMBI process. So I will show you how is the architecture of our prototype. So we have a central agent, which we call orchestrator. That's the one who guides through all the process to the user. The user is the AMS steward. And this orchestrator can call to one of each of these 5 agents. These 5 agents replicate the process that has been previously described by 7.4. We have a behavior science systems analyst. We have a barrier masters, which explores the barriers of the previous behavior. We have an intervention matcher, who helps to match the barrier and the best potential interventions. Then we have the implementation architect that helps to implement the interventions that have been chosen. And finally, we have an agent that will help the teams to choose the best way to evaluate the impact of the intervention that they design. So we try to follow the COMBI process. And each of these agents is composed by core instructions on what is the role and the personality and other features that explain how it has to interact with the user. And apart from that, they have an associated knowledge base on behavior change, knowledge base on AMS, knowledge base on interview, knowledge base on that complements these instructions. And they are integrated in a single platform. And okay, we have Session Sherpa. Session Sherpa is not in the process. It can be called throughout the process. If you want to build consensus online, on-site, it helps you with the sessions that you have to do grouping. And this is a video, but I don't know if it will work. You see the orchestrator in the middle, and the orchestrator calls the behavior system analyst. The behavior system analyst can respond to the orchestrator or can follow up to the barrier master, to the intervention. You see how it works? To the intervention master, it follows the process. Okay, it's the same process. That's it. And we are building, it's very important for us, how the user experience. We have to make this easy and adapted to the flow of a person who can have different expertise. And we want to create, what we are doing now is to assemble this technical platform into an interface that is easy to use, that is institution, also AKA team-based account, and it's project-oriented. You see, it should be to the left, it's the registration. On the second is how an individual user of a team sees the application. There are, in the lower part, the projects. ICU de-escalation is a project with several conversations. Surgical prophylaxis optimization could be another project. It's linked to the institution. And finally, on the right is how every chat works, which agent is participating in the chat, who is called, and there is a summary. So it pretends to be a specialized multi-agent chatbots to support teams to build interventions. And this is the architecture, but which brain are we going to use? And this is very important. Which LLM are we going to use? And this is very important for two reasons. We want to use a high-performance LLM, but we need to build a sustainable tool. And I will tell you. We developed conjointly with AEMPS Drive 30 case scenarios. Some were clinical and some were purely AEMS organizational. And they were mapped to the core SMIT competencies for AEMS and antimicrobial prescribing with low, middle, and difficult level. And we scored how they performed in general, the quality of the response to these scenarios. And then we also wanted to flag safety and fabrication. And we built traps. We just wrote the scenarios inviting to fabricate, no? And this is more or less the response that we had. They were blindly assessed by humans, I have to say that. And this is how they ranked in the quality score. And best is not GPT. That's one. Okay, good. It's just 2 more slides. And the best was Claude Sonnet. And if you see most commercial LLMs, which are less sustainable because you have to pay for them, they perform better than the overall open source systems. So we are planning to have 2 prototypes, one with the best commercial LLM and one with the best open source LLM, because sustainability is important for us. And you can see that the difference between one and the other. And also it was very interesting that with a very simple incentivation prompt, the performance improves significantly. If you do well, you will be hired in this AEMS, and you show the scenario, the performance was better. So it was very cheap to increase the performance of the LLMs. And the last subtask, this is the last slide, and it has to be coordinated with education, and it has to be coordinated with the toolkit. We want to, what we are planning is to organize a co-design workshop. It's very limited size, in order to build blueprint intervention for the most priority, for the most important behaviors, for the most relevant problems on antimicrobial prescribing in hospitals and primary care. We will need to choose 5. And during those 2.5 days, 2 teams will follow the COMBI process. One will use the AI toolkit and the other one won't use it. So at the end, we want to have a blueprint adaptable intervention because the blueprint needs to be adaptable to different contexts, but we will also test, pilot test, how the toolkit works in real life. And basically, this is what we are planning to do in 6.4. Thank you. And now, our people from task 6.1, AMS in human health, is following with the presentation.
Hello, everyone. So my name is María Núñez. I'm from Andalusia healthcare system, and she's my colleague, Blanca Bradley, at the Spanish Medicine Agency. So we are here also with Rocío Fernández, Antonio López, and so many colleagues, and Pepe online connected. And we are here basically, well, we are on behalf of 6.1, as José said, antimicrobial stewardship in humans. But we're here to say thank you, first of all, to all our amazing partners, collaborators, and all the work package that we all collaborating together as well as working. And I'm saying this because I have to confess that when we see the grant agreement every time, we are like, okay, JAMRAI is crazy. It's like so many things we need to do in such a short time. How are we going to manage? How are we going to do this? And it seems impossible. But after, if we could look back, and after we're going through months and months and we're going back, it's like it's become a reality. So someone said yesterday that if you want to have a nice recipe, you need to have good ingredients. And I think that's one of the main things that JAMRAI has done, especially, well, at least it's our impression in antimicrobial stewardship, is that the people here, the experts that the JAMRAI has been able to engage, they are brilliant minds, they are super motivated, and they want to work. So that's the title of our work in this program. It was like from paper to action. And I think we managed to do that. We want to show our actions, thanks to our colleagues and co-workers and everyone. So we'll show you some results. So what has happened from Bilbao to Vienna? Just a brief reminder is like in 6.1 we have like 2 lines of work. One is like we need to develop common frameworks on core elements, core competencies, like standardized, like working all together. And the second one, the other line that we'll see, is like bringing together those experts, those people, like more expert or with less expertise, but working on the field, to bring together best practice, share experiences, so we can do that together. So that's to foster this chain of experience and to foster implementation. So I hope not to press the black button. For the first line of work, the overview of current status of what AEMPS are. Well, we always say in all the meetings, we are not starting from scratches. There are a lot of things. So the first thing we had to do was like to trying to map, to talk to already existing initiative, other societies, say what's going on already and where we're going to start from. So that's what we try to do. We have a lot of meetings, we collect a lot of information, basically from international surveys. We conducted 3 surveys and also 3 on-site workshops, and they were about the 3 settings: hospital, primary care, and long-term care facilities. So they gathered like hundreds of participants. The response rates were amazing, and you will see some of the results now. And for the second part, I'm going to end up here. It was like we need to start this exchange program. So how are we going to do that? We started laying the foundations for those programs. First, we map what other programs were on track. We will also contact with the other work package to see how we're going to do these synergies, this interaction, so we can improve and use our resources better. And we started to develop with different working groups, like the standard procedures, how we're going to start, how we're going to do it. And also to match this expert, we need a digital platform. So to see which are the functionalities or the items required, so we can make further actions later. And with no more, I don't want to speak more. Blanca will speak later and close the thing. But we want to show a video so all our participants and partners and collaborators want to give their opinion on what we have done this year. So.
Hello.
There it goes.
Hello, my name is Bojana Bejovic. I'm an ID physician in Ljubljana, Slovenia. Close to 1% of EU population lives in long-term care facilities, mostly long-term care facilities for elderly. Antibiotic use in long-term care is a couple of times higher than in the community, and many residents are colonized or infected by multi-drug-resistant bacteria. This is why a part of Work Package 6.1 was dedicated to antimicrobial stewardship in long-term care facilities. The activity started in the survey that aimed to identify the situation in Europe and the coverage of AMS activities in long-term care facilities by national action plans for antimicrobial resistance. The survey was followed by a workshop that was held in May 2025 in Ljubljana. The results revealed large variations in the governance of the facilities in Europe. National action plans in several countries mandate antimicrobial use and resistance surveillance as well as AMS programs, but in most cases they have not been implemented. Practical solutions were proposed in the workshop, including harmonized surveillance tools and standardized education. Participants of the workshop from ministries, academia, and healthcare providers, including general practitioners working in direct care of long-term care facilities residents, emphasized tailoring AMS programs to local context while maintaining common core competencies. Thank you very much.
Hello, my name is Anne Versporten. I'm based in Belgium, and I attended a workshop on ambulatory care titled Building a Unified Approach in Europe, held in Madrid in 2025, which provided valuable insights into antimicrobial stewardship in primary care across several countries. Importantly, I found also that the role of rapid diagnostic tests, together with accessible antimicrobial prescribing guidelines, are practical tools to improve antibiotic prescribing practices in the ambulatory care setting. And there were really points of discussion. Moreover, evaluating the appropriateness of antibiotic prescribing in primary care also depends on good metrics, well-defined metrics, and relevant determinants, which are also essential for shaping effective policy responses. Clearly, investing in antimicrobial stewardship in the ambulatory care to promote appropriate antibiotic prescribing will reduce antibiotic pressure and by consequence also its impact on hospitals. The roundtable discussion sessions brought together professionals directly involved in EMS, and it was an interesting time, I felt. Importantly, the sessions helped us to identify similarities and also differences between countries, and that organizational models vary, confirming the need for a flexible framework. So thank you for listening to me.
It's a long video, sorry.
Hello to all colleagues. My name is Adonis Barakos and I'm working in Greek National Organization for Public Health. In Athens, experts from across Europe came together for a workshop supported by the JAMRAI 2 program with one main shared goal, strengthening antimicrobial stewardship in hospitals. Antimicrobial resistance remains one of Europe's most urgent health challenges. During this workshop, participants explored how hospitals can work within a harmonized framework that supports safer and more responsible antibiotic use. By sharing experiences and practical solutions, the workshop was a first step to shape a common European vision for hospital antimicrobial stewardship, moving from fragmented efforts to coordinated action and from knowledge to real impact for patients and health care systems. Thank you very much for your time.
Hi everyone, I'm Lucy Cato and I'm speaking on behalf of ESGAP, the European Society of Clinical Microbiology and Infectious Diseases Study Group for Antimicrobial Stewardship. ESGAP brings together experts around the world in order to advance the science and practice of antimicrobial stewardship, promote education, and support the implementation in diverse healthcare settings. In the context of EU-JAMRAI Work Package 6.1, ESGAP has been actively involved in shaping the work on antimicrobial stewardship in human health. We collaborated in designing 3 European surveys for hospitals, primary care and long-term care facilities, and contributed to the 3 face-to-face workshops by chairing sessions, moderating roundtables, and facilitating expert discussions. Looking ahead, we are excited to continue this collaboration and support the development of a European AMS framework, the peer-to-peer exchange programs, and the emerging digital platform that will connect and empower AMS professionals across Europe. Together, we believe we can strengthen AMS, improve patient care, and help make Europe a best practice region for antimicrobial use.
Hello. My name is Maria J. I am an assistant professor of infection prevention and control at the nursing department of the National and Kapodistrian University of Athens, and I collaborate with the Hellenic National Public Health Organization in the framework of the JAMRAI 2. Within a work package 6.1, I contributed to the development of 2 standard operating procedures under a common peer-to-peer framework for antimicrobial stewardship in human health, one for online mentorship and one for on-site observancy programs. The mentorship procedure provides a structured but flexible approach to support healthcare professionals across hospitals, primary care and long-term care facilities, focusing on peer exchange, capacity building, and implementable stewardship actions. The observancy procedure complements this approach through short, targeted on-site placements in hospitals and primary care, enabling the transfer of tested practices to participants' own institutions. Together, these procedures provide an implementable model aligned with EU priorities on AMR, with potential for piloting, evaluation, and scale-up within JAMRAI 2 and beyond. Thank you.
The last one here.
Hi, I'm Marta Gutierrez, and I'd like to share why I am excited about the EU-JAMRAI platform about to come, that will connect antimicrobial stewardship experts across Europe. This tool will make it easier for professionals from different countries to meet each other and share their knowledge, experiences, and best practices in a more direct and dynamic manner. Instead of working in isolation, we will have a common space to exchange ideas, solve questions among peers. The real value lies on how quickly we will be able to identify what works and adapt it to our local context. It's a great opportunity to strengthen collaboration and accelerate progress in addressing antimicrobial resistance together as a one European community.
Well, thank you very much. As you've seen, we wanted to be creative here, so that's why we brought this video from different perspectives to show what we have done during this 2025. So now I will just finish this presentation by informing on what is to come on 2026, as we keep on enthusiastic for the work we have accomplished over these past 2 years. This 2026 will bring we will keep on working on the development of these 3 frameworks on core elements and competencies, not only for hospital, but for primary care and long-term care facilities on stewardship. We will also be rolling out and piloting the mentorships and observerships, putting into practice the operational procedures that has been mentioned by Maria and also by and on the video. And also we foresee to see the launch of the tender for this digital platform that we will be hosting all the peer-to-peer programs and will be connecting experts around Europe. Finally, I would like to take the opportunity to thank all partners, as Maria said, and all collaborators for their work, dedication, and support. A special thanks, of course, for the colleagues that have been starring in this video. And of course, I won't forget Pepe for his always great work. And of course, this homemade video, he needs credits for this. So just to wrap up, drawing on all evidence that we have been gathering, also the insights from EU-JAMRAI 1, from other work packages and other EU projects experience, we think that everything will be contributing to strengthen the whole by adding value through synergies, interactions, and shared learnings. And so this is from our side. Thank you very much for your attention. And I believe we will have a short questions and answers session. So if my colleagues from 6.4 want to join. I'm not sure if I'm on the right place.
Is there any question?
Cannot see. Yeah.
Hi, this is Lukáš Macenaura from Czech Republic. Thank you for your presentations, and I would like to ask about the adaptability to different language variations, namely, the use of AI. That was very inspiring. So, shall we wait for the end of the pilot and then, try to get it to users in different countries? What's your take on this?
Yeah. I've used it in English and in Spanish, and it works well in both. That's what I can say. My experience now with LLMs, especially frontier LLMs, is that the language is less of a problem than it was previously. But I can't say that for every language. Spanish and English are quite, there's a lot of, the population base is higher and there is much more information there, everywhere there. But for sure, if you think if everyone in JAMRAI think this is a concern, and it may be, we can try to validate that, at least for some languages. We can choose some languages and choose because validation, it also takes time. And we should do it strategically to think if validation how. Thank you. Because our idea is afterwards, this is pilot.
Time for the others to make their questions. Sorry, José, that we have very few.
Okay.
Okay. Thank you for this nice questions. I'm involved in the veterinary who will be presenting now. But I was wondering, because this AI toolkit and also the digital platform, did you think of connecting us with that as well? Because that would be great.
Who is the question for? It's for
well,
me?
both. I think for the toolkit and also for the platform. I think it would be great if we, from the veterinary and environmental side, can benefit from that as well.
Yeah, we are developing and validating the tool mainly from the architecture and how it works with human health, because it's more information on how AEMPS are structured. So this is our first step. The second step is to find a sustainable way to incorporate this and choosing the LLM. And third is connecting their platform with our tool, because it's very much similarly oriented. It's team-based, it's individual-based from a team institution, and so that will be our part. Once the tool has been technically proven and validated, in 2027 we will try to approach the vets. But we'll try to do it, but the context is so much different that it will be difficult. But if the architecture works, if we provide the right context, it can also be useful for vets.
Well, I think it's you.
Can I jump in? Yeah. Related to the platform, of course, we are trying to include the animal health and the environment, also training materials. It is a question of and IPC as well, of course, sorry. So we are trying to build it, but there is some challenges on the tender, and of course in the sustainability, who's gonna embrace the platform when it is a One Health real platform is a challenge that I also give to the audience, to the ones that can solve it.
I think One Health was the initial approach, but it's challenging. So, yeah. There's one more question there.
Hello, everyone. I just want to make a comment, just coming back what else mentioned. Actually, first of all, thank you so much for your presentations. Very exciting to see these. We just want to highlight that the companion animal field is pretty much what you see in the medical setting. Unfortunately, we might not have your resources. So, if you're working in a referral third opinion practice, yes, you'll have resources like you have in a human hospital, but all the challenges that you mentioned here in relation to MS and IPC, behavior change, we are also facing. So that's why we were kind of thinking that, it would be very, very beneficial to work together. And, as you have been challenged in working on some of your, protocols for a little bit more time than us, I think that would be beneficial for us, and we will bring a different perspective, because infectious diseases are all around. Antimicrobial resistance is a problem. When we are veterinarians are much more than treating animals. We are responsible for public health. We have a really important role in that area. And, I think that our contribution is really, really important. And we have a huge responsibility as well in the impact of the environment. And of course, the farm veterinarians have different challenges, but, the principles of IPC and AEMPS are also applicable. I just wanted to clarify this because we've been working hard, and that many times we kind of think about livestock production, which is really, really important to produce safe food for people, but we also need to have safe animals and with good welfare. And all of these together will have an impact in the environment. So really, we really need to work all together because our end goal is to have a healthy planet, because only then we can have people that are healthy, animals that are healthy, and mainly keep our ecosystems working. Thank you.
Thank you very much for your comment. I just want to give just a brief comment. We fully, completely agree. We even for the workshop, we included, in our partners in discussion table, we invited people from environmental, from veterinary, to do this One Health approach, but like in reality. So we have discussion table, like we have these challenges and problems with governance, with implementation. So they could give feedback and to speak the same language, because at the end we all find this huge heterogeneity, also similarities. So we're not starting from zero. So where we started, how can we organize and put it all together? I'm sorry, because she wanted to say.
Just 1 second to say that we don't have.
Can I say one thing only?
Okay.
Sorry, can I say one thing, very brief? Just following on else there.
I'm sorry, but we really need to
give me 30 seconds. Only 30, I think it's important for this.
We are going to be on the info point, all AMS together, because we do actually work internally.
Yeah, I could have said it already. Els and myself have taken the certificate for the SMIC, and if you include us in we are the organizers of those parts. So if you include us in the emails, we will jump whenever we can. That's it.
Okay. But anyway, we will be on during lunch on the AMS point, so we can talk and discuss. Thank you, and sorry for taking the time. Now, of course, is my colleagues from veterinarian side and also from the environment. We do work closely together from the first moment, so we are aware that we need to have one health approach and every sector is important here. So, Maria, this is your turn. Isaura.
Thank you, Blanca. Yeah, just wanted to reinforce what Blanca is saying. In AEMPS, we are sitting all together in the same building, so we work very closely. Unfortunately, the resources are what we have. Anyway, this is Isaura from Utrecht University. Sorry. And I'm Maria Vilar from the Spanish Agency on Medical Devices. And we are going to give you a brief overview of what we have been doing in this antimicrobial stewardship in animal health. So as you see earlier this morning, as you see earlier this morning in the video shown by our colleagues in IPC, we are working together, closely together to elaborate evidence-based guidelines, standards for AEMPS and IPC, while enable engagement of different stakeholders. So very briefly, to remind you what was one of the outputs from JAMRAI 1, and it was to create and elaborate a white book on implementation and development of efficient and sustainable AEMPS programs. And that was because although the existing guidelines, tools, programs that already are in many countries in Europe, they differ greatly in terms of aim, animal species who are addressed to, in terms of who produced those guidelines, and also the type of document, if they are policy brief, research papers, and so on. So having those things in mind, we are preparing and drafting two different frameworks, one for companion animals and another for food production animals. And they are intended to be a practical tool for all member states to develop and implement sustainable and efficient programs at national and animal sector level. The idea is to have those frameworks as an overarching perspective to facilitate their adaptation to the particularities of each member state and also to the animal sector. And for doing that, we have a lot of partners, highly motivated and committed with this work. And they organize, or we organize ourselves in 4 different working groups, one for cattle, another swine, poultry, and companion animals. And they are working together, having regular meetings online. Yesterday, we have our last meeting face-to-face with really great discussions. So we are drafting those guidelines. And those guidelines are, sorry, I wanted to say a lot of thanks to all of you for your great work, because otherwise we won't be able to do this within JAMRAI. So to create these frameworks, we are using, or you are using, your own expertise and experience on the field. We are using information collected from the workshop we held last year in Bilbao, as shown in the video earlier this morning, but also some information from the literature review conducted in collaboration with Federation of Veterinarians in Europe, that they review the all available programs, guidelines, tools on AEMPS worldwide on animal sectors, plus a survey that was conducted also last year to all different member states to collect non-published information. And with that, we are preparing 2 documents nowadays, and they have 2 different sections. One common, where there is the definition, different definitions, where it has a description of the objectives of these frameworks, the methodology, and the approach on how to use them. And they have a more specific session, different for each animal sector, where we define the different core elements, the different core competencies, and some indicators to assess the progress of implementation. So regarding the core elements, each working group followed their own approach to select which one should be included in the framework. But we use overall as a reference the WHO toolkit, and we were able to identify 6 overarching core elements like leadership, accountability, education and training, monitoring, surveillance, reporting and feedback, and some technical pillars for AMS. Those technical pillars are strategic or actions or activities with the objective to optimize the use of antimicrobials to improve treatment outcomes, and also to reduce the antimicrobial resistance, but also in the selection of the appropriate antimicrobial and alternative therapies if they are available by conducting diagnostic tests. And I pass the micro.
Yes, thank you. These guidelines for AMS, they are not only containing the core elements, but they will also contain the core competencies, which was already mentioned in all other work packages as well, the people who are going to do it, and also we are also thinking and including the skills the people need. And we are also developing indicators, or in other words, the levels of implementation. So we started with 3 levels of implementation: basic, intermediate, and advanced for all these core elements. But as Maria mentioned, we had yesterday also discussions again, and then we discussed maybe 2 is enough. So this is still in progress at this moment. So this frameworks, guidelines, they are finished this spring, this year. And then we have the first draft of these guidelines. And if you can follow me with the blue line, you see, well, we have a first draft, but of course the working groups, as we said, we have split them in 4 different working groups, but we, of course, all the guidelines need to be shared and reviewed by the other working groups, so all of the partners. That's the first loop. Then we are going to the second loop to review them much better with our colleagues of the human side, behavioral experts, and at least the last loop also environmental. So we have good reviewed guidelines. And it comes as no surprise that, as you could see in the core elements, a lot of, those core elements include some overlap with other work packages: surveillance, IPC, and access. And of course, we prevent overlap. So we discuss where is the overlap, and maybe some parts, like biosecurity was just mentioned yesterday, of course, that needs to be in IPC. So we are in close contact. And with that, we have reviewed guidelines. We expect to finish them in fall this year. And then we want to implement them further. So we have another working group, a really great working group, and they are going to organize peer-to-peer trainings in 4 regions of Europe. We will start this fall with that, and next to that we will identify mentor and mentees, and we do peer-to-peer actions with basically the goal to also to implement and further improve these guidelines, basically to test them out in the field and to see how that is going to be. And of course we take all these experiences together to include in our expert network. So to summarize this, we also have a roadmap. You already saw the start of this roadmap in the presentation of IPC. I see some people laughing. It fits perfectly with the car from yesterday and the plane, everything. We started with evidence, the surveys, the literature reviews. We have the workshop where you see the movie from IPC and AMS on this morning. We want to have engagement, so we made reports, publications. We have the focus groups from IPC. We need alliance. We need the expert network for AMS and IPC. And finally, this year, capacity building. We also start a series of webinars, Voices from the Field, based on experience from last year. We wanted to have more case studies, really practical studies from the field to be told to all the partners. And of course, we are going to do the peer-to-peer activities, all to have the results, the frameworks for AMS and IPC at the end of the EU-JAMRAI 2 period. And to give you a glimpse of that, this morning we started with the video of the workshop in Bilbao. Now we are going to show you a video how we are going to take all these steps together for the upcoming time, the upcoming year. Well, thank you. This applause is basically for the communication team. Thank you for making two really great videos for us. We are going to pass the word to my colleague of environmental, but we still have a Q&A session after this. So here is Anne.
Thank you. Okay, good morning. I'm a co-leader for antimicrobial stewardship in the environment, so I'm pleased to present the progress of our work this last year. I will begin with the roadmap of our task to provide you with some context. Then I will focus on presenting the two main results we achieved in 2025. And to finish, I will outline our next steps for this new year that begins. Then, as you know, we need to implement a pilot training program on environmental AMS. And in 2024, our work focused on laying the foundations. So we identified our priority target audiences and built a strong network of collaborators. We also identified gaps in knowledge practices and attitudes related to the issue and reviewed existing training materials on the topic. So building on that work, 2025 was dedicated to developing operational tools. We created a digital tool to support the selection of training methodologies and formally designed our pilot training program. So over these 2 years, we also had the opportunity to meet in person. We had 2 workshops that were very crucial to moving the work forward, and especially the last one was very important because we gathered all the people working in environmental health within this joint action, and we also had all the colleagues from human, veterinary, and communication teams involved. So it was very good to align our strategies. And then looking ahead, we can say that 2026 will be the year we deliver concrete materials and activities. So we are now transitioning between the design and implementation stages. Good. Focusing on the first result from 2025, according to the grant agreement, we had the mandate on using innovative training methodologies that could generate deep, sustainable, and transformative capacities. So we explored theories of adult education and a variety of innovative training methods. And then we compiled all the information found into a preliminary report. And in this document, we categorized 25 different methods based on factors like the learning modality, costs, or, for example, time considerations, and also created a matrix of recommended methods according to the different professionals involved in AMR that included many different profiles from healthcare workers to food producers or even wastewater managers. So next, we proceeded with a consultation exercise to validate this matrix. And then we conducted 2 focus groups where representatives from the key target audiences participated in guided discussions. And I want to again highlight that these focus groups involved people from all the different fields. So even if this came out from our task, which is focused on environmental health, it can be very, very useful for anyone wanting to develop trainings on AMR, regardless of if they are focused on human, veterinary, or environmental approaches. So yeah, this is the result. You can find it on the website. And well, finally, after these focus groups, we got a validated report, but it was almost 200 pages, so it wasn't exactly the easiest thing to use. And therefore, we decided to make it more practical and user-friendly, and that's how the idea for the digitalization came about and led us to reorganize all the content into an interactive online tool. And this is how it looks like. And I also want to acknowledge the communication team, because they've been crucial for the contracting and also for the digitalization of these contents. And please, if we can see the video, so we can learn more about this tool.
First, access the EU-JAMRAI 2 website through your browser. Next, go to the Training and Education section and scroll down to the AMR in the Environment section. Once there, access the digital tool by clicking on the blue box. At the top, you will find a summary with a description of the tool. Further down, you can start using it to select the innovative training methodology that best fits your objectives and available resources. You can learn more about specific methodologies by typing their name directly into the quick keyword search bar. If not, and you prefer the tool to suggest methodologies based on certain criteria, expand the advanced search using the filter system. You'll be able to filter based on different criteria, such as the target audience, learning modality, training environment, etc. Before selecting an option, you can check its definition by clicking the question mark icon to the right of it. Once you finish selecting your filters, the tool will return the recommended methodologies based on those criteria. Click on the name of a methodology to access its step-by-step implementation guide. You will find a table of contents on the right to help you navigate the content. The step-by-step guide includes a clear planning outline for the selected activity, a description of the relevant participant roles, recommended evaluation methods, and a prototype that serves as an inspirational example of this type of activity in the context of antimicrobial stewardship. It also includes a summary of the scientific literature that supports the content. If you wish, you can easily download the guide by clicking the button in the top right corner to save it as a PDF on your computer. On behalf of EU-JAMRAI 2, we hope this tool inspires and supports you in delivering meaningful training interventions that advance antimicrobial stewardship and contribute to long-lasting impact within this joint action and beyond.
Okay, so this is a tool, this is available online, and we will be, well, presenting it during the corner meetings. It's called AMS Info Point, so if you want to learn more and navigate together, you can come approach us. Then, yeah, so once the tool was launched, we started using it internally to choose the methodologies for our pilot trainings and further define our program of activities. So we set the filter system to include all learning modalities and a high level of interaction while keeping time and cost moderate or low. Then we discussed different options suggested by the tool and went for the community of practice because we felt that it was the most complete approach as it can combine a variety of methodologies within a single setup. And now another video. Let us tell you a bit more about our community of practice and the program of planned activities that we have.
A community of practice is defined as a group of people who share a concern, a set of problems, or a passion about a topic, and who deepen their knowledge and expertise by interacting on an ongoing basis. What is the goal of this community of practice?
Our community of practice, or COP, focuses on the environmental dimension of antimicrobial resistance within the European Union. Aligned with the One Health approach, our goal is to 1. Bring together relevant stakeholders across sectors, 2. Raise awareness and build knowledge on the environmental dimension of AMR, and 3. Promote the integration of environmental strategies into AMR policies and practices across multiple settings.
How is this community of practice actually going to be built?
So we are going to use a hybrid approach with both online and in-person activities, and we plan to do this in 2 steps to move from learning to practice. First, we will create an online space where participants from the different sectors can find learning resources to understand the environmental dimension of AMR, and once everyone has a shared understanding of the issue, we will meet in person for hands-on sessions that will be very practical, giving participants a chance to work together and learn how to apply these best practices in their own work.
Who will be part of this community of practice?
Collaboration and knowledge sharing are at the heart of the COP, bringing together a diverse range of stakeholders across the One Health approach. We have identified the key sectors and professionals working on environmental aspects of AMR, and they will take part in the pilot project through their representatives and institutions. Many of these participants have already been actively engaged at the national level.
We aim to strengthen AMR governance by integrating environmental strategies into Europe's national AMR action plans.
We are committed to expand stewardship in healthcare to include environmental perspective and sustainable management practices.
We will promote awareness of the AMR's environmental dimensions in the food production and the animal health sectors, and will support the implementation of best practices that can help reduce AMR spread.
We aim to support the upcoming implementation of the European Union recast Urban Wastewater Treatment Directive by building capacities to curb the dissemination of antimicrobial resistance via wastewater.
Please visit our website to stay informed of the COP's ongoing advances.
Thank you very much to the contributors as well, and to Victor for helping me with the editing. And finally, what's next? Well, we are currently working on creating content to feed the online platform of this COP, and we will present these contents at the 3rd year workshop in June, and I am pleased to announce that it will take place in Athens and be hosted by the Hellenic National Public Health Organization. And after that, we aim to design and implement in-person activities starting in the 2nd half of the year. So that's all. And now I call back Maria and Isaura on stage.
There is some time for questions from the audience, so don't be shy. We cannot see you, so. If not, we will ask you directly, so it's better you ask first.
We also have a mentee.
Yeah, that's why I'm
with them.
Yes, I think that's a good idea. If there are no questions in the, then yeah, can we put the Mentimeter on?
Anyway, there will be follow-up questions to them, so.
Yes.
We cannot see you anyway.
We cannot.
Maybe you can just speak.
Yes, this one. So everyone can log in with their phone. Hopefully.
Okay, so you want to start? Because first questions are on animal health.
So maybe we can, I don't know if I have to press the black button for this or no. No. Our first question is regarding the core elements we have selected. We have not mentioned all of them during the presentation, but you can run which ones do you think are more relevant in companion animals. So monitoring and surveillance.
Yes.
So we see here the importance of collecting data on antimicrobial resistance, but also in antimicrobial use. So.
Yes, as the work package about surveillance is about resistance. I cannot see where Lucy is, but she is somewhere here. This is more about the surveillance, like the use of antimicrobials for companion animals and how important it is for AMS. And most of you agree, and also education and training is high up. But the technical AMS actions, they are staying behind.
Interesting. Yes. Okay, let's go to
the next
food production
question.
animals. Oh. Same question, but in food production animals.
And to see if you think a difference is needed for food-producing animals, which is interesting, because of course, food-producing animals, they are in a completely different context, and a lot of you are doing human medicine, so we are curious.
If we can move one.
So, yeah, can we go to the next? Yeah.
Interesting, the third one.
Yeah.
Until now, there's more focus on the regulations and policy. Is there someone who wants to comment on that? Why they think that's the most important for livestock?
And also, if you miss any other core element, either in companion animals or in food production animals, that we should consider and be included in the guidelines, we would like to hear from you. Nothing. We are perfect. Okay, so let's move to the next one.
Yes, I think that's...
So people, that question is about who are the professionals more needed in these programs. And you can also vote for the ranking.
Is there someone that is saying, like, I miss an actor here in this list? We would love to hear that.
Pharmaceutical industry.
Mm-hmm. Yeah, the industry, yeah.
Yeah,
okay.
well, industry is there. But
Yes. Meat consumers, someone is saying?
Why
like
only
the public?
Consumers?
Sorry?
Come to discuss with us in the info point.
Yeah. I think it's good to go to the next question because...
Okay. So we are now moving from the animal domain into the environmental one. What should be the ultimate goal of environmental AMS strategies? And this is a discussion that we are having internally. As it is an emerging topic, we are wondering maybe if the ultimate goal is protecting human health or the ecosystems themselves, or maybe animal health as well. Plant health protection is also raising, and well, we have this concern with fungicides. Good, so this is quite similar to the responses that we are getting internally, not now, because there was a change as I am talking. Okay, so you think it's ecosystem health protection? Yeah. I know, it's just like a prioritization exercise. But it's not leaving things out. Well, we will take this into account because it's not exactly the result that we have internally. So maybe we can next into the next one. It's okay. Not yet. Now. So how can antimicrobial stewardship frameworks be expanded to include environmental approaches? This is another discussion that we have, and this has been mentioned already in the IPC session as well, that we have a term that cannot fit into environmental approaches, or maybe it should be adapted. So do you think that we should be integrating environmental considerations into human and animal AMS strategies, for example, like you did, that you are including this section about manure treatment in your AMS guidelines for food-producing animals? Or do you think that we should develop context-specific core elements for environmental AMS? Or both? If you want to comment on this. We don't need to choose one or another. We could go for both.
We will happy to follow up all these questions in the info corner. So if we don't have time now.
Actually, we have 20 seconds to go. Okay, so do you think mostly that we should be integrating environmental considerations, which I think it's very feasible and quite easy to do? Or the easiest strategy, at least, I would say, as long as sectors are open for collaboration, of course.
Well, we are.
I know you are. Yes, we have another question, but I think we can leave it here. Yes, and continue the discussion in the meeting point.
Yeah, thank you.
Sorry. I would like to introduce and give the floor to Marta, who will do the closing remarks of this session. Thank you.
Thank you. Thank you, ladies. Well, for the sake of time, I'm going to read, and hungry. We are hungry, so I will be brief. Good morning, everyone, those here and online. As we wrap up this discussion on the work done in AMS working package, it is time to reflect some remarks. We are in a pivotal moment. These last 2 years, our task leaders, together with the several partners, shaped the plan, built consensus in procedures, and created foundations for the future tools that will guide our work ahead. Now we move from planning to implementation. Our working groups are already active, working on the frameworks, guidelines, and training materials. Networks on AMS experts will be fed in the coming months, and tools and programs need to be piloted. So for that, we need the collaboration of all of our partners and stakeholders. So I do not want to end this AMS update without saying thank you for the work done to the whole team. and thank you for the commitment to accept the challenge ahead. Our technical officers will be in the info corner during lunch today and tomorrow during the coffee break, so please do not hesitate and visiting us for further information. Often time is not enough to go in deep in some subjects, so we will be happy to chat with all of you, and thank you very much.